And without further ado, I'm so pleased and honored to introduce Dr. Keith Humphreys. He is the Esther Ting Memorial Professor in the Department of Psychiatry and Behavioral Sciences at Stanford University. He's also a senior research career scientist at the VA Health Services Research Center in Palo Alto. His research addresses the prevention and treatment of addictive disorders and the interplay of science with public policy. Dr. Humphreys has been extensively involved in the formation of public policy, having testified to Congress on multiple occasions and having served as a member of the White House Commission on Drug-Free Communities, the VA National Mental Health Task Force, and the National Advisory Council of the U.S. Substance Abuse and Mental Health Services Administration, or SAMHSA. During the Obama administration, he spent a sabbatical year as senior policy advisor at the White House Office of National Drug Control Policy. He also testified on numerous occasions to the UK Parliament and advises multiple government agencies in the UK. He created and co-directs the Stanford Network on Addiction Policy, which brings scientists and policymakers together to improve public policies related to addictive substances. He also led the Stanford-Lancet Commission on the North American Opioid Crisis, and today he is going to give us a presentation on that great body of work. Dr. Humphreys, welcome.
Thank you so much, Dr. Darnell, and my friend Beth Darnell, and thank you also, Ashley Gomez, for setting this up so wonderfully and giving me a chance to speak to this audience. And good morning to all of you who are tuning in, or if you are on the East Coast, good afternoon. I'm trying to put my slides up, just people can see. Okay, it's telling me, terrific. Okay, so I'm going to talk about the Stanford-Lancet Commission. And the most precious thing about us all being together is that, versus say watching a talk on YouTube, is that you can participate. I know many of you have been working at the coalface, have lots of interesting and important things to say. So I promise you, I will end with 15 minutes left. And so you can make your comments, ask questions, and so on, which I think is very important. Okay, let's see if this is working here. There we go. Okay, so this is the required slide, and there's more here than you could possibly take in, but these slides are available to you. It just explains how you can get your CME credit. And there's also an email up there in the corner, maybe the most important thing. If you have questions about how to do that, they can help you. They're very good at our CME office. I'll give you my disclosures. Actually, first, let me say how important disclosures are in the area that I'm talking about. As we'll get into today, there's a lot of money sloshing around, analyses of the opioid crisis, and sometimes it's money with an agenda that doesn't get disclosed. So I want you to know, first off, that the commission had no connection to any industry at all. We were very fortunate to have an unrestricted philanthropic grant from Stanford University School of Medicine. So we could say whatever we wanted to say and be candid with what we thought, and that's what we did. Commissioners weren't paid. They very kindly volunteered their time. This is a report of the commission. It doesn't necessarily affect the official views of either my employers, Stanford and the VA. It doesn't reflect official views of the Lancet necessarily, or any of the organizations that employs or works with our commissioners. If you want to read full disclosures, they're all there in great detail on the Lancet's website. So when Lancet asked me to do, actually I should say, for those who may not be in the health field, Lancet is a journal based in Britain. It's one of the oldest health journals in the world. And it runs commissions on different topics that are considered important to global health. And so they approached me and said, would you do something about the opioid situation in North America? And so I assembled a team, about 18 people, 10 here at Stanford, and then the other 8 from around the US and Canada. Very importantly, we tried to have a diversity of views. This is an issue that opioids and pain and addiction are issues that divide people very easily, and people go into warring camps. And when you do that, it's easy to imagine that there's no basis for agreement. And we didn't want to do that. So we had people who are experts in pain and experts in addiction. We had people who are experts in law and criminology, and people who are experts in public health, and tried to bring them all together. And I think we did pretty well with that. In terms of the experiences, we had people, of course, who treated patients, people who were scholars, researchers, people who were teachers, educators, people who worked in public policy. We also had people with lived experience of addiction and chronic pain. We worked together over 18 months, and we set a standard among ourselves that we would not recommend anything unless we could get to 90% agreement or more. And I'm happy to say we were able to do that on many, many important things. In fact, usually we got to 100% agreement on the things I'm going to show you today. Here are the members of the commission, some of which you may recognize if you work in health or in law for that matter. I also want to acknowledge, in addition to the people who served, we had some terrific advisors, Professor Richard Frank of Harvard University, Ann Case of Deaths of Despair fame, who's a professor at Princeton, Shelley Greenberg, who's a professor also at Harvard. We're also very grateful to Tom Coderre. My friend Tom was part of the commission, and then the Biden administration stole him from us. They made him wisely the acting assistant secretary and then the deputy assistant secretary at SAMHSA. So he had to step down, but we did benefit from his wisdom at the beginning. So let's talk about the status of the crisis. And actually, the first thing I want to tell you is why the word crisis. When the Lancet approached me, they said, we want you to write about the opioid epidemic. And I said, I would like to not call it that. And let me tell you why. If I say Ebola epidemic or cholera epidemic, the solution is you want to eliminate all the cholera or all the Ebola. But we don't want to eliminate opioids. We need opioids to take care of people. So I didn't like that framing. There is an epidemic of opioid addiction and opioid overdose, but it's not an epidemic of opioids per se. So we picked the word crisis instead to reflect that it's about how opioids are used, and also because part of the crisis remains poorly managed pain. So you will see that throughout what I'm going to go through today. How did we get to the very sad situation where we are today, where all of us are reading the paper and seeing over 100,000 of our fellow citizens dying every year in the United States? It happened in 3 waves. It starts in the late 90s. Prescribing rose very, very fast for a bit more than a decade. And with that, we had more people getting addicted and then more people dying. Then we have a second wave that starts around 2010. What happens then is traffickers who produce heroin figure out, there's money to be made particularly by converting people over who were using drugs like, say, OxyContin or Vicodin or whatever. Heroin is much cheaper. And so they started setting up shop in towns and cities that hadn't historically had heroin of any significant amount. Towns like Youngstown, Ohio, and Steubenville, Ohio, and Parkersburg, West Virginia. And heroin was deadlier, and then you see more deaths coming from that. And then last, and the most horrible thing, is then the infiltration of the illicit drug market with synthetic opioids, most famously fentanyl, but not just fentanyl. And that turned what was already a serious problem into a complete public health disaster. That is the reason why we're now experiencing over 2,000 deaths a week, if you can believe that. Now, very importantly, these waves aren't completely discrete. It doesn't mean the fact that we have all these deaths from synthetic opioids that no one is having any trouble with heroin or no one is having any trouble with prescription opioids. The waves lay on top of each other. And if you look in the stories of individual lives, you will find plenty of people who their death is reported as a fentanyl death. But if you knew their whole story, it may have started 15 years ago with diverted OxyContin, and then some years of heroin use, and then finally their death from fentanyl. So these things are connected. This is a very sad map that was in our report. First point I want to make about it is some people think it's just an American thing. It is not. Canada is suffering horribly. They also have a very serious opioid epidemic that in fact is accelerating. Opioid crisis, which is accelerating faster than ours. But to give you, it's hard to say, like, what does that mean, up to 72 deaths per 100,000? So I'll give you a comparison point. If you're my age or older, you certainly remember HIV/AIDS and the terror of that crisis, particularly early on, when we didn't know what was going on and we didn't have any treatments. At the peak of HIV/AIDS, the acute death rate in both the US and Canada was lower than it is now for opioids. So this is shockingly even worse. I'm particularly grieved also. You see the darkest spot on the map is the state of West Virginia. That's the state where I'm from. And every time I go back there, it's just shocking and tragic for me to see what has happened in that part of the country. but it's certainly not unique to that part of the country. It really is at this point everywhere. The racial makeup and ethnic makeup of people who are dying has changed a lot. So I think the public has in their head the idea that this is an Appalachian thing. And it was, at least in part, early on, but now it's everywhere. So we charted the course of different groups. So whites were absolutely affected disproportionately early on, and African Americans were comparatively insulated. But with the arrival of fentanyl, particularly its penetration of markets for cocaine and heroin, African Americans are now suffering horribly. In fact, they've caught up in a very short time to whites, and they have the fastest growing death rate. Indigenous peoples in both the United States and Canada have had a terrible time all the way through. They were as high as the whites at the beginning, there's as high as whites and blacks. Now that's the group that's been hit the hardest. Hispanics, Latinos are experiencing more harm due to fentanyl, but are still not as severely affected. And one of the, I suppose, positive stories we could probably understand better is Asians and Pacific Islanders have suffered, but hey, they've been mostly insulated. And I frankly wish, a journalist asked me when this came out, why is that so? And I wish we'd thought more about that. As a commission, we tend to focus on the things that are going badly, but what is going on in those communities that seems to have some protective effect. How bad could it get? This is the commission model, which you can get. I'll give you a website in the end where you can get everything we did for free, but this is on there. This is our projection for this decade, that if we don't dramatically switch what we're doing, we will lose over 1 million people to overdose from 2020 to 2030. There are other models, including models I've advised and works on, that are, I wouldn't call them more optimistic, but they're less pessimistic, but they're not encouraging. But less the more, if you want to say more optimistic model, they're still projecting hundreds of thousands of deaths. The reason models differ is we're having to judge two things that are very hard to judge: how long does COVID last, and what is it like over the years, and what are the long-term impacts? And second, how rapidly is fentanyl going to spread throughout the country? But I think the exact number is less important than to say this is a really, really important public health problem, and we need to get on it, or we're going to be just in even worse shape than we are right now. And while all that's going on, we still have terrible problems with pain. So one way to look at it is, well, we had this huge ramping up of opioid prescribing, but if it made pain management really good in the United States, you might say, well, that's a huge cost to bear, but maybe at least we got something out of it. But tragically, as you all know, this is pretty recent work. We still have 20% of US adults reporting chronic pain and 8% reporting high impact chronic pain. So we're not doing a good job there either. And we tried very hard to think about these two things together. They are intimately tied. If you're going to deal with people getting addicted to opioids and overdosing opioids, you have to also deal at the same time with the fact that we are not doing a good job taking care of people who need pain management. Where did this problem start? I will tell you our analysis of the commission. So it came about, at least in part, from absolute legitimate concern about poor pain management in the United States. We have epidemic levels of pain. We don't do a good job taking care of it. And many of the people who were pushing higher and higher prescriptions were completely decent, caring people trying to do the best by their patients. But it was exploited by people who make opioids and people who distribute them. So companies like Teva, companies like Johnson & Johnson, companies like Purdue Pharma, as well as distributors like Cardinal and McKesson, dramatically pushed the medical system to increase opioids far beyond the level that it was actually being helpful. Now they're all being sued. They're mostly losing. Some have been held criminally responsible. So in the simple version, they are the villain of this piece. But one of the really important things to remember is lots of people failed who should have done a better job. What they did was unconscionable, but it's not as if they could have done it on their own. There are really substantial failures in the regulation, in the law, and how we practice healthcare, how we educate our practitioners. So lots of people are complicit in this problem. And the reason that's important to understand is if we don't fix all those holes, there's no reason this precise same thing couldn't happen again in 10 years with, say, stimulants. prescriptions, or benzodiazepine prescriptions, or some other drug that hasn't been approved yet. So we have to both hold the industry accountable and also recognize we, so to speak, are also part of the problem, and we need to do things differently. As I mentioned, where did these illegal opioid markets come from, which are now driving the problem? Well, they're a response to what we did in the healthcare system. And it's a good lesson about how if you lose control in the system you can control, then you start losing control generally. And then the last thing is that COVID made everything a lot worse. And why is that? Well, you could think about there's good things that help people avoid drugs, and there's bad things that may drive them towards drugs. And COVID takes away the former and increases the latter. So you have many people who are isolated, bereaved, maybe have lost their job or just lost daily structure, who maybe seek drugs as a relief from that. And then the good things that would compete with drugs, things you might like to enjoy, are also in shorter supply. And they're, whether it's getting out and seeing people or having fun, a whole bunch of things have been hard for us in the age of this pandemic. And so it's not surprising that we've had this horrible increase during COVID, about 30% overdose deaths in most cities in the first year of COVID, and in Canada, twice that fast, if you can believe it. So the commission went after this in 7 domains, excuse me, but for sake of time, I'm going to focus on 4. I picked the 4 that I thought that would be of most interest to you. And here they are. First one is, as I said, I'm going to talk about this as a case study in multi-system regulatory failure. Second, talk about opioids' dual nature as both a benefit and a risk to health. They are not bad at all. It's a matter of how they are used. And I'll get into that. Third, about why we need systems of care for people who have substance use disorders, including opioids, but not just those who have opioid use disorders. And last, how do we stop this problem that is ravaging the US and Canada from spreading all over the world? So first, this crisis is a case study in multi-system regulatory failure. This gives you some international data. This is the peak of US prescribing, which was about 2011 or so. And data comes from the United Nations, and the treaties oversee opioid consumption. So we actually have pretty good data internationally on how much different nations consume. And you can see the US there is really off the chart in terms of where it compares to other developed countries. And Canada also is not as high as the US, but also pretty high. And it's not as if, if you look at nations like Norway, France, Sweden, Italy, they're giving bad care there. They actually have healthcare systems that most ratings would say are better than the United States. So it really was something that wasn't maximizing our well-being. Neither is it just that we have more pain. The United States is actually a younger country than a lot of the European countries. And international surveys, our pain is pretty similar to what's reported in France and Italy, which are, as you can see, down around the middle of the chart. I do want to emphasize, though, at the same time, it all depends on how you use it. So for example, I will cite Germany as an impressive example in that they have the 3rd highest, almost as high as Canada, but they have no signs of opioid, or certainly nothing like the opioid addiction and overdose we see in North America. And that's partly how they control prescriptions, partly how patients interact with the system. So you can provide a lot of opioids and not have bad things happen, but that's not what we did in the United States or Canada. So why did this happen? Well, one of the things that is really notable about the United States is how much money there is in promoting the use of all drugs, certainly including opioids. So this slide is it's the most recent data we had, which is fortunately a little out of date, 2013, but it makes the point. So that these are in billions of dollars, billions with a B. The bluish circles are how much individual pharma companies are spending on R&D. And then the orange is sales and marketing. So you can observe a couple things here. All of them spend more money marketing and selling than they do developing new drugs. But the second thing worth knowing is the entire budget of the Food and Drug Administration was smaller than the marketing budget of the 10th biggest company. So you can see they are pretty outmatched. And, this is, some people know, is that like the little gifts and trinkets people give to doctors? Yes, that's some of it, but it's much bigger than that. One of the interesting things, the United States and New Zealand are the only two countries on earth that allow medications to be advertised on television. It always strikes my friends from other countries when they see our TV, like every ad seems to be saying, take a pill, take a pill. And even though opioids aren't televised advertising, there is the message that there is a solution for everything. It is a pill and you should ask your doctor about it. And also the industry does some bank shot advertising, like advertises a pill that relieves opioid related constipation, very famously $10 million ad purchased during the Super Bowl. So we have that marketing, and it works. There's a reason the companies do it. They have very good information on how much prescribing there is, and they're doing this because it works. We've also had a fair amount of corruption, I'm embarrassed to say, because I am, a professor in a medical school. We had a lot of corruption in medicine, in both individual doctors doing things like presenting themselves as neutral experts while taking enormous sums of money covertly. And we had corruption in the medical schools. So by that, I mean things like students being given industry-produced materials as if they were objective scientific information. We had Tufts is very interesting. I'd suggest you read this report. Tufts removed the name of the Sackler family from their university. But the report that led them to do this, they showed, for example, Tufts faculty doing an advertisement for Purdue Pharma, taking a lot of money from Purdue Pharma. And they even had, it was sort of interesting, the book Dreamland, which is a very good book by Sam Quinones, had been chosen as sort of the Tufts book. Each year, the medical school picks one book that every single person in the medical school gets a copy of so they can read about it. And that was chosen, and they de-chose it to avoid offending the Sacklers, which is interesting because apparently Sacklers didn't even ask for that. But the school was so structured around, we need to keep these people happy because they keep the dollars flowing. Sacklers, of course, I assume you all know this, just in case they owned the company Purdue Pharma. So that corruption was a problem. Students got told things that weren't true. Had some terrible problems with the revolving door. So the FDA official who approved OxyContin for Purdue Pharma, and with a fraudulent label saying that it was believed to be less addictive, a year later was working at Purdue Pharma at about triple his FDA salary. Similar things happened when the DEA tried to stop distributors from dumping millions and millions of pills to different regions of the country. The industry simply hired away some DEA lawyers who then started working for them very effectively to stop them. And we had problems with fake grassroots groups. This tobacco industry pioneered this with smokers' rights groups, but there were a number of groups that presented very compelling testimony as the independent voice of pain patients or whatever, and it turned out they were just industry creations. The most famous one is the American Pain Foundation. I think we reported 88%, it might have 90% of their budget came from American Pain Foundation. Now, to be clear, grassroots groups have a right to exist. They have a right to advocate for health, and it's okay for them to take some donations. But when you take 5% of your budget from a company, they're helping you out. When you take 85%, you're helping them out. This was a problem in that they misrepresented the situation to policymakers and the public when they were really mouthpieces of the industry. The lobbying data, this is kind of stunning. This is a 10-year study by the Associated Press and Center for Public Integrity on state level lobbying. And that tiny little orange slice is millions of dollars spent by families trying to do something to constrain the industry at the state level, 4 million. And the red is industry spending trying to expand their business with lobbying and donations. And you can see that's 880 million. They have a 200 to 20 to 1 advantage at the state level. It's no wonder they often get their way. Same thing true at the federal level. I will really recommend these articles. They were written by Scott Hyams, Harry Horowitz, and Lenny Bernstein at Washington Post. The book is American Cartel, and the article there, you can read the Post write-up. And this is about how when DEA finally went to places like where I grew up and said, you're shipping, 100 million pills over a decade to a town with 500 people in it. Cut it out, you're not supposed to do that. The industry was able, through putting a lot of money into the Congress and also hiring away some key DEA officials, to simply get the law changed. The DEA didn't have the power to do that anymore. And as we note in the commission, one of the key House member who got a lot of corporate money and push this, was then nominated to be the drug czar of the United States. Fortunately, he had to withdraw, but that shows the level of what I would call corruption. So what are we going to do about all that? Well, we recommend that, pharmaceutical product promotion needs to be curtailed. And there's a number of ways to do that. You could outright ban gifts and incentives to doctors, or you could make it non-tax deductible, because currently the public subsidize all of this as a legitimate business expense. We also suggest constraints on pharmaceutical advertising direct to consumer, even though opioids aren't managed or aren't marketed directly that way. It does create a sensibility that everything can be solved with a pill. We need to insulate the medical education from industry. There are many interactions between medical schools and industry that are hugely productive, stimulate innovation, help students, help the quality of care, but there's also risks. And one way to handle this is to let, if a company wants to donate money to a medical school, a nursing school, a dental school, a pharmacy school, it has to be thrown over the fence kind of money. In other words, it can go into a pool and the school can use it as they wish, but the industry should get no control over how that money is spent or what the course material actually says. We note the problem with the revolving door between industry and regulators. It's only a year at the moment. I think that's too short. We endorse some legislation that would make it 2 years. We also say on the positive side, it wouldn't make sense for the public sector to pay very talented people more. So if you are in a regulatory agency and you're extremely skilled at evaluating, say, proposals for new pharmaceutical medications and devices, why not reward that person to retain them working on behalf of the public? In terms of fraudulent grassroots groups, sometimes called AstroTurf groups, we think that can be addressed partly by changes to fraud law and also partly by SEC, Securities and Exchange Commission reporting, whereby if you were a company funding a group that is intended to push your products, you would have to disclose that in your annual filings and it would come out. It would also help a lot if legislatures and journalists, whenever interviewing someone from an advocacy group, asked, are you say you really want more of this product, may I ask you, do you get money from the people who make this product or not? And last, we've no hope for this happening anytime soon, but we do think that the unlimited corporate donations to political campaigns creates a lot of problems, but it certainly made the opioid crisis worse. And so as quixotic as it is, we wish we could see a restoration of limits on that. So now I'm going to talk a little about opioids' dual nature as a benefit and a risk to health. This is a good book. I don't like the title, but I like the book. It's by my friend Mike Stein, who's a great addiction researcher and an internist, and also a really good writer. And this is about a woman he treats. He calls her Lucy, who is taking 30, 40, 50 pills a day to sustain her addiction to opioids. And she has a quote, "I don't remember what normal looks like. What you feel every day, I feel only when I take my pills." And that is the sad part of opioids, their addictive potential. This statement is about a patient I took care of in hospice. I worked in hospice for 10 years. And he said, the most terrifying thing about my cancer is not my coming death. It's the memory of my grandfather in the hospital, screaming for God to kill him because he was in so much pain. It was wonderful for me to be able to say to this young man, don't worry, there's been incredible advances in pain management since your grandfather had his illness. And the pain docs on the team will help you in ways they couldn't help him. And a lot of that's going to be about opioids. Everybody's scared of fentanyl. And I have journalists ask me all the time, why don't we ban this evil, evil drug? We don't ban it because it's an incredibly useful drug. If you have stage 4 bone cancer, a fentanyl slow release patch is the difference between misery and peace. And we can't forget that. So this is from my friend Sean Mackey, who was on the commission. This to me was the most important quote. No offense to any other commissioners, but this just stayed with me. We should not be pro-opioid or anti-opioid. We should be pro-patient. There's nothing wrong with opioids. They're not good. They're not bad. They're just a molecule. It's all about how we use them. And we need to get to a situation where we're making these decisions based on the benefit to what each individual person needs. How do you do that? Well, first off, you need a national strategy. We do have a national drug control strategy. We put that out every year, but the United States lacks a national pain strategy. there was a very comprehensive strategy put together right at the end of the Obama administration. Sean was one of the leaders of it, but it's just a terrific document. I mean, it goes through prevention, education, management, healthcare, community work, and we call on the Biden administration to revive that strategy because I think it's extremely sensible. And by the way, it's not a national opioid strategy. Obviously, opioids are part of the solution, but it's a national pain strategy, which is bigger. And if you have a sensible approach, you're more likely not to have these kinds of problems. Can't emphasize enough to think about the supply of prescription opioids as a dial, not a switch. So we had 10, 15 years where people just sort of threw the switch and said, the more, the better, the more, the better, the more, the better, which was bad. Now we have people grabbing that switch and wanting to throw it the other way. These are bad drugs. The less, the better, the less, the better, the less, the better. When you do that, you ruin people's lives. You know, there are people who've been thrown off their pain medications who desperately need them. Some of them, you know, become depressed. Some of them tragically take their own lives. It's not something to be done in such a crude way. Because they're not bad, they're not good. They can be useful. And we have to get out of this idea that we need to have unlimited or just incredibly scarce. It's a dial. There's some point between those two that is the right one, and that's what we should be looking for. Any policy has to anticipate and ameliorate potential adverse impacts. So for example, when we started doing prescription drug monitoring to make sure people who were having, 5, 10 doctors writing scripts, and we restricted them, there wasn't enough done for those who were addicted to be immediately directed to treatment. And so some of those people then went to heroin, and they went to fentanyl, and then they died. Likewise, at the moment, in sort of the rush to cut down opioid prescribing, some people are having their pills removed in ways that are harmful to them. And so we should be always thinking ahead, like, this is going to work for one problem. Who might be ill affected by it? We need more trust in medicine. The opioid crisis damaged trust in medicine. Trust in physicians is down. And I think the best way to do that is for doctors themselves to be the leaders of safer prescribing initiatives. Some parts of the country, they really were the resistance to doing anything about it, to their shame. That was a mistake. But the smart thing now is rather to be dragged kicking and screaming for the people who actually do the prescribing to be the leaders. And we're seeing more and more of that around the country, and that's good. And the last thing is we need to use the electronic prescribing and monitoring systems better, and they need to be better systems. If mandatory PDMPs work for reducing harm, but they're a real pain for people to use. They're clunky, they're slow, they often have wrong information. So investing in improved technology and also reimbursing people for checking doctors, pharmacists, and so on is really important. Last point I want to make, and this is an idea that has gotten traction, it's in the commission report, is FDA needs to think more broadly about how they approve drugs. So currently, an FDA application, what they look at is, what is the effect of this drug if the person to whom it was prescribed takes it exactly as intended? And that doesn't work so well for addictive drugs because people very commonly don't take them as intended because they get addicted to them. And second, because they have high market value, they often end up being sold. And so we call on the FDA to broaden and look at those things as well. What happens if not just the patient gets addicted? How risky is this drug? What happens if the patient's kid takes it out of the medicine cabinet? How risky is it? What happens if it gets sold? Will it interact with current illegal markets to cause addiction and death? And this idea has been pushed by the national academies. We push it, and it's really gotten traction. The FDA circulated very tentatively, but they did circulate a draft policy of this sort. And I was really pleased that Peter and Josh, who were high up in the FDA when I worked for President Obama, have also endorsed this. This is a JAMA viewpoint on it, which is a really good thing. Okay, third point, what about people who have substance use disorders? The most important thing to understand about addiction care in the United States is it was not birthed in the House of Medicine. So, geriatric medicine didn't exist until Medicare, and suddenly seniors had insurance, and then medicine said, wow, now let's take care of these people. And then the first geriatric medicine fellowship was started by doctors right after that. Addiction care doesn't come about that way. It's always been lightly funded, if at all, in the healthcare system. Instead, it comes out of the criminal justice system, the social welfare system, like Salvation Armies, and the mutual help system, AA and NA. and those kinds of groups. Now, all of them save lives, all of them have done some good, but none of them are actually healthcare. And until we bring addiction into healthcare, make it as mainstream as going to your doctor for any other condition, we're going to continue to have people unable to get care and also people getting poor care. This is a disturbing study about poor care. This was a secret shopper study. And what they showed is that a number of residential addiction treatment programs in the United States were forcing people off FDA-approved medications because they didn't believe in them, which can put people at high risk for overdose. It's terrible. I don't think we would tolerate this for cancer care, but we tolerate it for addiction medicine because, again, it isn't really seen quite as being healthcare. So what do we do about that? Well, we think we have to permanently mainstream addiction care within health and social care systems. It should be as normal as cancer care or as heart disease care. I worked a lot with the Congress, like they passed the Support Act in 2018 to respond to the crisis. There was a lot of good stuff in there, but they didn't get to the point where they just said, let's just permanently support this kind of care. There's a lot of focus on 2- and 3-year grants, as if addiction is a problem that if we just work hard in 24 or 36 months, it will be gone. But that's not what it's like. It's like heart disease or cancer. It will always be with us. So we have to permanently equip the healthcare system to handle it. And we talk in the report in great detail about how to accomplish this. Part of this is about regulation. Private insurance is virtually all of it is now subject to something called parity rules, meaning you have to cover addiction and mental health the way you cover other types of disorders, but those rules are often broken and they need to be better enforced. And then on the public side, we need to make sure that the quality of care is excellent. That given in the system I work, VA, which I honestly am quite proud of what we do. But we also have our shortcomings. There's also the military health system, the Indian Health Service. There's FQHCs, where the federal government is directly involved and can be doing a lot more to make sure everybody can get access to substance use disorder care. And last, curtailing provision of harmful treatments, like the ones I pointed out in that secret shopper study. The simplest way to do that is to stop paying for them. So if we just said, look, if you're going to kick people off your medications, you are not reimbursable anymore. That will cause change pretty fast. Last, how do we stop this crisis from getting outside North America? Something that really disturbs me when I travel to other countries, people say, oh yeah, opioids, that's America. What do you expect of America? Only in America could that happen. First off, it's not even true now. Canada is almost in as bad shape as we are. But second, these are multinational companies. There's no reason this can't happen all over the world. And here's an example. So this is an investigative series by LA Times, by Harriet Ryan, Lisa Garian, and Scott Glover. And they had a lot of information from inside Purdue Pharma. Now, just make sure everyone knows. So the Sackler family owns Purdue Frederick, they own Purdue Pharma, and they also own Mundi Pharma. All those companies have produced OxyContin, and the court cases have closed and bankrupted Purdue Pharma and Purdue Frederick, but the family is untouched. They will not spend a day in jail. They walk away billionaires, and they have another company, Mundi Pharma, to do exactly what they did in North America and every other country. And that's what this story is about. And these are some of the countries in which they are actively trying to promote their drugs. Also important, the laws and the regulations in the United States, including things agreed to in the court judgments, don't apply outside America. So even if there's a pledge and a requirement, you can no longer secretly pay doctors, or you can no longer try to corrupt a prescription drug monitoring system or electronic prescribing to push your product. That only applies in the US. You can go straight out and do it somewhere else. And multiple companies are doing that, not just Mundi Pharma, but certainly including them. These are just some of many, many studies of this where we're seeing, corruption scandals, ridiculous promotion. I mean, the Chinese story is particularly amazing because it's people going into hospitals wearing lab coats who are not even physicians telling everybody to use these drugs. So it would be a real shame if we didn't help the world learn from our mistakes and they suffered as we suffered. And it is working. They are increasing opioid prescribing pretty dramatically. Some of this is going to be good prescribing. It's prescribing for people actually needed for pain. But we know when things go up really, really fast, there's usually a lot of prescribing that should not be happening, and some people are being harmed. I could have picked many other countries. You can go to the UN website if you want to see, but this is a trend you see in lots of places. Now that coexists with something else, which is there's plenty of countries that do not have enough opioids. And this goes back to one of our central points. They're not good and they're not bad. You can have too many. You can also have too few. This is a really vivid map made by a different Lancet Commission on palliative care and pain relief. And it makes countries bigger on the map based on their opioid supply. And when you look at it that way, you see, wow, North America is huge, Australia is huge, Europe's kind of big, and every other country is squeezed into this little space because they have almost no opioids. People are dying in horrible pain. People are going through surgeries without adequate pain relief. It's very difficult. And that's why we endorsed their suggestion to not use the tragedy of North American prescribing to stop people in, say, India from getting adequate pain relief. How do you do that? So you have to do some constraining on the US side. We need to constrain our producers from exporting fraudulent and corrupted opioid promotion practices to other countries. That's the least we could do for our fellow citizens on this earth. But then those countries need pain relief, and they have kind of a tough choice. You can either, if you have nothing and your citizens are suffering, or you have to make a deal with a profit-seeking company that's rapacious. That's not a very attractive choice. So we say, let's get the companies out of it. Let's just give them free generic morphine for analgesia. Could coordinate it through WHO with donor nations. It's not expensive. So they could have the pain relief they need without falling into the arms of companies that are just going to do to them what they did to us. So I only got to 4 of the 7 domains. We also have discussions of criminal justice, of the need for innovation and for the need for prevention. You can see all that. You can also download any of the materials from the commission and read who everybody is at the website opioids.stanford.edu. It's all public domain and available for you. Thanks very much for your attention, and we now have time for questions.
Wonderful. Thank you so much, Dr. Humphreys. We have several questions that have come in, and I'm not sure if you can see the chat. The first one, has there been significant research regarding military personnel versus civilians with opioid addiction throughout the United States and abroad?
Yeah, that's a great question. Particularly during when the conflict in Iraq and Afghanistan was at its peak, there was a large amount of people leaving the service already addicted to opioids, who have had severe injuries. Sometimes they had to get opioids in far forward medicine. And we see that reflected in the VA system. We have been disproportionately, veterans have suffered disproportionately compared to the rest of the country. And there's multiple reasons for that. First, as I said, there's people who become addicted to opioids from very serious battlefield injuries. But other reasons are the characteristics of the population: disproportionately male, disproportionately rural, and also disproportionately socially isolated. And all those things are risk factors. So as this epidemic has been worse for people, military personnel and former personnel, than it has for the rest of the country.
Thank you. Another question, have you personally been a paid expert witness in litigation? I assume this is related to opioids.
I have never been a paid expert witness. I've been asked at least 10 times by both sides, by the way, to testify in these cases. And I chose that I didn't want to do that, nor have I ever taken any money from the opioid manufacturers or distributors or anything like that. That's just where I felt comfortable positioning myself, because I wanted people to know I had no interest other than what I just told you.
Great, thank you. What steps are suggested to improve the comfort of medical practitioners in collaborating with non-pharmaceutical practitioners, such as chiropractors, acupuncturists, et cetera?
So that's a great question. I mean, you have to be, I'll think about my home state, okay? So you find community practitioners, they have people come in, maybe you've been hurt in the minds, they're in a lot of pain, and they would like to do something else, but they really can't. Maybe the person only has Medicaid, and it's like, I'll refer them to the local, physical therapist. Well, there isn't one. And so doctors have to do what they can, and they're human beings, and they say, well, I can at least give you some relief this way. And that doesn't come about randomly. That comes about through decisions we make about how we finance healthcare. And there's no reason why, I've been a chronic pain patient. I got physical therapy. Man, it was a miracle, I have to say. That should be really well covered in all our plans, and any non-pharmacological approach that works should be paid for and give people more options. And by people, I mean both the providers and the patients, rather than saying it's opioids or nothing.
Thank you. This from Sean Mackey, wonderful presentation. Keith, can you share with us how you have taken this document to influence policy in the United States and beyond? What impact has it made? What do we need to do? And your next steps.
Thank you, Sean, and thanks for the terrific work you did on the commission and on the national pain strategy. So of things I've done in my career, I can't think of many things that's had more interest from policy people. So I immediately, right after this came out, we had invited briefings at the White House for the counselor to the Secretary Becerra, for head of FDA, NIDA, number 10 Downing Street in Britain, and a huge amount from state legislatures. And different people pick different things that are of interest to them. So some of them it's, tell us how to make electronic monitoring systems better. I'm going to the United Nations next week to talk about how do we balance this question of how do you help poor nations have more without getting them into the problems that we're having. And I'm really, really, really happy that the heads of the Lancet Commission on Pain Relief and Palliative Care, Felicia Nall, is working with us. And Sean is part of that effort, and other of our commissioners are, to try to find that balance around the world. I think that's one of the most important things that we could do to show that it is possible to have these medications, have them make people's lives better without spiraling into the kinds of problems we've seen in the United States and Canada.
Great, thank you. What advice would you give to junior researchers who are looking to make a difference in OUD treatment? What are some research priorities that you believe should be pursued in the next decade?
That's a really good question. So one of them is the co-occurrence of pain with opioid use disorder. It's a really common thing to see. It's really tough clinically for everybody to figure out what to do. And there's very few people actually studying that question. What do you do with that very vulnerable population of patients? So any, good trials in that area, I think would be really extremely valuable. Also expanding the range of treatments we have for opioid addiction. I mean, we have 3-4 medications. Compare that to anything else, depression, asthma, got dozens and dozens. So, other countries are using, as we point out there, there's people using injected methadone, people using slow release oral morphine, people using hydromorphone. These are, countries with strong healthcare systems. They seem to know what they're doing. Why don't we try some of those things? So instead of saying, we've got these choices, which are pretty few, say, at least I need 2 hands to show you all the options I give you instead of 1. That would be a step forward to that kind of evaluation.
As someone who is a pediatric chronic pain provider in a major pediatric hospital system, I'm interested if Dr. Humphreys can speak to the effect or variance of adult opioid addiction, whether it's attributable to inadequate or unavailable chronic pain management in teenage and young adult populations.
Okay, so let me say first off, my expertise in pediatrics is nil. So I would just have to talk about what I know from as an addiction person. Almost all addictions start when people are young, not old. You walk up to a 50-year-old smoker and say, when did you start? They'll almost never say when I was 42. It's when they're teenagers or early adulthood, because the brain is the most plastic, neuroplastic at those ages. That's when we acquire addiction most rapidly. So in the long term, right now we have to deal with people who are thick in the middle of this problem, but in the long term, better management of pain, and that may mean sometimes using opioids when we should, and other times not using them when we shouldn't, in adolescence, in young adulthood, is the long-term solution. So you have the next generation not go through what the current people my age are currently going through with this problem.
Great, thank you. Keith, I'm going to ask you a question. For people who have been taking opioids long-term and, perhaps the medications have been benefiting, in some cases, maybe they're not benefiting, but these are people who've been on medications for a long time. And as a consequence of some policies that have been put forward, those people are being tapered off of prescription opioids, generally force tapered, sometimes too rapidly, sometimes the pace isn't the issue, but we have seen a lot of iatrogenic consequences from these policies. And I'm curious, because you're a policy expert, how can we approach this better so that we're protecting everyone? We're protecting people from, falling into the addiction crisis, but we're also protecting people who need opioids, and we're also protecting people who may need to taper, but we're not doing it in the right way. So just curious if you have some thoughts on that.
Yeah, that's a really good question. So we do point readers to the DHHS tapering guidelines as sensible advice for collaborative thinking about this between prescribers and patients. And that's a really nice document that you can see for free online. The more general issue, we talk about that in terms of trust. How did policymakers get between doctors and their patients? So we don't want policymakers between doctors and their patients. And that has to do with the loss of trust. So we had, when, say the Florida State Medical Association blocked any effort to stop those pill mills for year after year until 7 Floridians were dying a day and they finally had to relent. Things like that make policymakers think doctors are the enemy. Mm-hmm. And so therefore we need to get in there and control patient care. Generally, when policymakers do that, it's bad because they don't know what they're doing and they impose things like, no one may be prescribed more than 3 days because I said so. And that's where patients really get hurt. So, we need to restore trust. And that's partly how, why we say, let's lead, let's be the ones who say, yeah, we are for safe prescribing and we are changing what we're doing, which in fact, a lot of people are. You can count on us. Please release the control. Let us show you what we can do. We can do a better job. That we think is the practical way of restoring trust from policymakers and also from the public.
Great, thank you. Narcan has become increasingly available to prevent opioid overdoses, but now sedatives like xylazine are being incorporated, which have no reversal agent. What is being done with respect to this new twist?
Yeah, it's really tough. So we had a model that was led by Isabel Rao and Margaret Brandow of what investments could you make in the next 10 years to save lives. And the thing that came out as the best investment was increasing access to naloxone, which has reversed at this point over, actually, it's got to be more than this. I was at a Senate hearing in August and it was 300,000. So it's certainly higher than 300,000 people had overdoses reversed by it. But you're absolutely right. That is an opioid antagonist. It does nothing to anything else that might be in the drug, or if a person has co-administered, as is often the case, maybe a big dose of alcohol and some benzos as well. I don't have a simple answer to that. There are people pharmacologically working on reversal agents for other types of drugs, but it's never been as easy, just as it's never been as easy to develop pharmacotherapies at the level we have for opioids. It's more complicated. The binding in the brain is more complicated. So, a lot of places are trying to adjust the standard doses of naloxone in the hopes of at least responding to the really potent opioids like the fentanyls and the carfentanyls that are now out there, but it doesn't touch the issue you're addressing. And it's a real challenge.
Does genome sequencing have any role in, I think it might be pain medication or addiction?
So it's, we are all hoping for personalized medicine, for the care of addiction. And my read of that literature is that we don't have any. We've tried a lot of things like different studies of genes that affect, say, metabolism, and it just hasn't worked out to the point where I can say, give me a sample of your DNA and I will know that you need this medication versus that medication. It's one of the, actually, this might go back to the question was asked earlier about what do we need in treatment. That's another thing, would be some personalized data, so a physician could describe who's going to do well, say, on naltrexone versus methadone versus buprenorphine versus something else.
Great. Thank you, Dr. Humphreys. What about the idea of establishing pain centers of excellence here in the United States that would be solely responsible for handling folk that need long-term high-dose opioid treatment, that would take it out of the hands of the PCPs and help prevent diversion while humanely treating those who legitimately need this type of treatment?
So I'll just expand on that point. We were given the job by Lancet to focus mainly on the addiction and overdoses, but most of what we said about the addiction care system, you could say about the pain care system. So when you say like there's not enough money being spent on proper education, we don't have enough professionals, the care is not adequately reimbursed, that is all true of pain as well. And I'm not a pain expert, but I see better management of pain, including by that, but you're talking about developing specialty centers. That's part of how medicine develops, and having those things I think would be a terrific resource for people with pain, but again, also to help us with the problems of opioid addiction and overdose.
What are your thoughts on safe consumption sites for helping with the opioid crisis?
Well, my read of the two things. So it is absolutely true that if someone has an overdose and they're right in front of a healthcare practitioner, you can save their lives. And in fact, I think there's been only one documented death worldwide in these sites. So if you look at it that way, so that's of course good, like, that's a humane thing to do. At the same time, the first of those sites was founded 30 years ago, and there's, I think, 150 on the entire planet, including in societies that are very different than ours, politically and culturally. So I don't think it doesn't seem to spread very well. So it's not scalable, I guess is what I'm saying. So I don't think that's going to make much impact compared to think how much easier it is to spread something like naloxone, which can go anywhere, just this nice portable thing. So I doubt, I mean, we'll keep arguing about it, I'm sure, and we'll still have some, but they will not, in my opinion, move us one way or the other particularly.
Okay, thanks. Yeah, there was another person chatted in about the future of safe use sites. So I think
yeah, actually, this is something else we talk about, because we did get innovation is, and I'll give me a chance to promote Beth's great work about, we just also, if we had new ways to take care of pain, if we radically expanded things like virtual reality interventions that work, and cognitive and behavioral interventions that work, and if we could develop biased agonism molecules, so an opioid that didn't slow down your breathing, for example, that's the kind of thing that would be game-changing in the way a couple of consumption sites are not going to be.
No, that's a terrific point. I think we might have time for one more question. How do you reduce incidence of medical practitioners urging patients to stop alternative non-pharm interventions and instead get real medicine, such as opioids or other medications, to increase the incidence of collaboration?
Yeah, so I mean, doctors overwhelmingly want to do the right thing by their patients, and when they don't, it's usually a matter of education or economic incentives. So for all those problems, my first thing I always think about, does the practitioner have the right information so they know what will help? And second, is our system incentivizing the practitioner so that they're economically rewarded, not economically punished for doing the right thing? Okay.
Last question. Would Dr. Humphreys be willing to allow a patient panel of patients on opioids with and without OUD that could help advise on policy?
Oh yeah, like as I said, we actually had people with those experiences on the commission. I spend most of my life talking to people who are in, plenty of people who are in addiction treatment, or have sought it, or are still actually using drugs. Our clinical trials network has a group of people currently using drugs on it. So, I mean, I have big ears, and I'm always happy to hear from people.
Wonderful. Thank you so much, Dr. Humphreys.